Good evening, sir.
Good evening. There's some confusion about the meeting, and so I was, I logged in the same thing, but it usually took it as a different meeting. Anyway, we will start now. All right. Can you see my slides?
Yes, sir.
All right.
Sir,
Yeah, go on.
with your permission, we'll
Yeah.
just pay condolences and homage to Professor Rajesh.
Absolutely.
Ballal.
You please go ahead and mention it.
Yeah.
Some of the students may not know who we're talking about, so just give a brief about Rajesh and C.R. Ballard, sir. Yeah, please go ahead.
Professor Rajesh Ballal actually was part of this group, and he used to come on and impart his wisdom and always share his extensive knowledge and clinical experience with us. He has attended many classes. He was professor of surgery at KMC Mangalore and also in KS Agri Medical College. He was a very illustrious surgeon and a very good teacher and an extremely good human being. He also happened to be the son of a very, very erudite, illustrious, and extremely popular teacher and professor C.R. Ballal, who was a professor and head of the Department of Surgery at KMC Mangalore. He was nationally and internationally recognized as a very good teacher, and unfortunately we lost him this morning. So I think he was a good friend to Dr. Lakshman and myself, and we really sorely miss him, and we pray that that his atma gains sadgati and the family gains strength to really endure this very tragic and very untimely, very he was very, very young, 57 or 56, 57 years old. So it's a very sad day for us, and all of us should pray for his sadgati. Thank you.
Yeah, I second that completely. Rajesh was a very good friend, and his father, C.R. Ballard, was our senior and teacher to our generation of surgeons, an excellent teacher. It's a great loss for him, and our heart goes out to him. Our sincere condolences to him. All right.
Thank
So
you.
now, before I actually dive into the actual subject, I'm happy to welcome our registrars at Rangadorai. We have Sanat. Can you please open your videos so that people see you? This Vivo 12219. Who's this, please? Yeah, there you are, Sanat. Yeah, this phone Vivo 12219. Who is that? Is that Praveena? Hello. Okay. Professor Srivatsa is here. Honestly, it's very nice to see you, Srivatsa. Welcome, and I'm looking forward to your inputs. You will find that this is a discussion which is informal, and we always welcome, points of teaching, and it's very nice. And do I see Praveena here? I don't see. Praveena is our other registrar, and Vishnu is a registrar who joined us today. So I don't know if he is logged in yet. Praveena also I don't see. Srivatsa, nice to see you. You have opened
Thank
your.
you.
I do see Praveena here. Can you unmute Praveena? You have your hand up. Unmute and yeah, she has put her hand up. Praveena, can you hear me? Yeah, there you are. You unmute yourself, please. Can't hear you because you're muted.
Yes, sir.
Say hello.
Hello. Yeah, I'm here, sir.
Vishnu. So you're
Yes,
Vishnu. I'll rename him. He's
Sorry,
our
sir?
third registrar, just joined in today. I'll rename you. Okay. Just hold on. Okay. So we have our postgraduates, Nikita is a registrar in Sagar, but others are all postgraduates. You'll see their names as you go along. Okay. Sorry, Srivatsa.
No problem, no problem.
Good evening, sir. Good evening,
Okay.
sir.
So we have an interesting group discussion today. Carcinoma rectum is actually a vast subject. We'll try and compress it within an hour, maybe even shorter. I have some declarations to make. Most of my information that I'm going to show you came from NCCN guidelines, ESMO guidelines, and the professional version of the National Cancer Institute, NCI. And I've used AI in a very limited fashion, A, to get some information and get it quickly, get some references, and B, it gives you nice tables. You'll see some tables or tabular form of information. And I've used that so that I can put up some concise summaries for you in the slides that go along. So as I said, this is not a didactic lecture, but a group discussion. I will call out the person and I would like them to unmute and give an answer. Okay, the very first thing we need to understand is relevant surgical anatomy. For a surgeon, I'm not talking about the origin and embryology and this and that of rectum, but from a surgeon's practical point of view, what do you think is the relevant surgical anatomy? For me, the distances from the anal verge would be a key in deciding what we need to do. So can I have Malavika telling me what she thinks about the division of rectum? Malavika, are you there? Can you hear me?
Yes, sir.
Go on.
Don't waste time. Come on, quickly.
Ainas, I've given you a direct hint. Distances from the anal verge.
So it will be the upper, mid, and lower rectum, sir.
Correct.
It is 10 to 15 centimeter from anal verge is upper rectum.
Yes.
5 to 10 centimeter mid rectum, and lower rectum will be less than 5 centimeters.
Yeah, I think you're right. It's a little 1 centimeter off. It doesn't matter. Okay. So the anorectal junction, the rectosigmoid junction is about 16 centimeters from the anal verge. Okay, or 15 centimeters. And the upper rectum is 12 to 16 centimeters. Mid rectum is 6 to 12. And lower rectum is 0 to 6. Remember that the anal canal itself is about 3 to 4 centimeters long. Okay, so those are relevant things. Why do you think it's relevant, Ines?
So the approach, surgical approach will vary based on which part of the tumor lies.
Surgical approach is one, and then what else is important in the context of a cancer?
So like minimally invasive procedures will be.
That is the approach that comes under the approach part of it. Yeah. It depends on the margins, how much margin you give, and whether you can. In the lower rectum, the overriding importance is the sphincter complex. Whether you're going to preserve it, organ preservation as it is called, or whether you have to go for an APER. That is the relevance of the distances from the anal verge. Okay, so what is your idea of a mesorectum, Samir?
Sir, mesorectum is the one which involves the rectum, sir. Okay. It was described by Professor Hield.
Yeah. It wasn't described by him. He described the total mesorectal excision, but the concept of mesorectum was known in anatomy much before that. Yeah, go on.
So,
what is its importance?
So that is the wholly plane, sir, where like we take the whole mesorectum for margin, sir. Like
why do you want to do that? What margin is it that you're concerned about?
CRM, sir.
CRM, correct. Okay, so this is your anatomy. You have a mesorectal fascia. It's a very distinct fascia. After you have done your resection, anterior resection or APAR, you can actually see the nice fascia if you have taken it out completely. Most surgeons, experienced surgeons who take it out completely, always look for the integrity of this fascia. So if you take this tissue which is marked here, I'm showing it on my, let me show it here. Okay, if you look at this part of it, where what I'm drawing a line on, if you take this part of it, that has to be taken in toto. Extremely important. If you leave any bits of it, you will be leaving cancer behind. And I'll show you the importance of that as we go along. But as I said, circumferential margin is the most important thing. We're looking at safe margins. I'm going to talk about it later. We'll come to it again, but a hint is already given. As far as the CRM is concerned, a clearance of 1 millimeter is all that you need. Okay, remember in a classic cancer, the longitudinal gap that you have to give, we were talking about it in cancer colon in respect to it last Monday. What is the minimum longitudinal, proximal or distal clearance that one has to give? Samir. Longitudinal, not for rectum,
5 centimeters.
colon has to 5 centimeters. Okay, that is the real margin that you have to give. Rectum, there are differences, and I'm sure you know about it. We'll discuss it as we go along. But as far as the CRM is concerned, the circumferential resection margin, 1 millimeter is all that you need. Okay, right. Next, we will go to the right clinical workup. I'll need to erase this once I do that. Yeah, go on. What do you think you have to do for a clinical workup? Praveena, tell me.
Sir,
start with the simplest of things.
Digital rectal examination.
Excellent.
Sir. DRE.
What will DRE tell you? Good.
Any superficial carcinoma which is present, we can make out. And
Superficial.
also we can.
Are you sure?
Sir,
you
there
mean
are
distal
deep
or
and
superficial?
So there are deep and superficial carcinoma. The superficial carcinoma is movable, whereas deep will not be movable while doing a DRE. So we can make out if it is the depth of the carcinoma, sir.
Okay. I think it is one of the most inaccurate methods of looking at the depth. I wouldn't buy that, but yeah, distal tumors you can feel yourself. Okay.
And one more is sigmoidoscopy, sir.
Is that all you do about DRE? What else can you glean from that? The circumference that is involved, would that matter?
Circumferential, yes, sir.
Yeah, look at this. Okay. You can look at the tumor distance from the anal verge. That's the most important thing. You can look at the sphincter tone. If you're trying to preserve the sphincter, you want to know whether it's working initially or not. What you're talking about is mobility and fixation, not necessarily depth. Yes, I agree. Fixation is a part of depth as well, but it is not an accurate assessment. But you want to look at the mobility and what part is involved, anterior, posterior, or lateral. Okay, these are the things that you get from a digital rectal examination. You said sigmoidoscopy. Sanat, is sigmoidoscopy enough if you have a cancer in the rectum? No, unmute yourself, please. Unmute.
You hear me now, sir?
Yeah, you're fine.
Good evening, sir.
Good evening. Yeah.
Yes. Sir, we have to do a complete colonoscopy, sir.
Yes. Why?
Because there can be 5% of cancers which can occur simultaneously.
Excellent. It is called synchronous lesion. You're right. So yes, you have to do a
30% of polyps also can be there.
Correct. So you have to do a full colonoscopy. Sigmoidoscopy is not enough. And you can use multiple diagnostic biopsies in various, as you said, polyps, other things, proximal lesions, to know whether it is just an adenoma or not. And if you do discover more polyps proximally, you may be able to offer them primary treatment for rectal cancer, whatever shape it takes. We will discuss that as we go along. And endoscopic polypectomy can be done. So those are the reasons. Is there a role for rigid sigmoidoscopy at all? Nikita, you want to have a go at it?
Not in the current practice, sir.
Not in the current practice. But earlier, they used to say that it gives you a good estimate of the distance from the anal verge. With a flexible sigmoidoscope or a colonoscope, you can't get the kind of information you want on two things, the actual distance and B, the orientation. You'll never know whether it is anterior, lateral, or anterolateral, or whatever, because it depends on the rotation of the scope. But in a rigid scope, you can get the exact distance from the anal verge, you can get the orientation, but it is completely inadequate because, can you tell me the reason, Nikita? Okay, the clinical assessment of the distance from the anal verge is inadequate because after you mobilize the rectum, okay, completely down to the at surgery, down to the pelvic floor, the distal margin of the lesion can, I'm not saying always will, but can move up to 1.5 to 2 centimeters, so that you can then think about organ preservation or sphincter preservation or not. So the actual distance from the anal verge, while it is good to have an idea at a clinical level, can be determined with accuracy only after mobilization of the rectum. Ravi, anything to add?
I think the colonoscopy, one more thing is many of the times, especially there can be patients with inflammatory bowel disease on which the tumor happens. So I think it is good to do a full colonoscopy rather than just a sigmoidoscopy. And other thing is also, if there are multiple polyps and if the patient is young, you may want to consider, because of the fertile field theory and the adenoma carcinoma sequence, you may want to consider doing either a subtotal colectomy or whatever. So I think colonoscopy is necessary for these reasons.
Yeah. So Srivatsa, anything to add, please?
Nothing.
Yeah.
Sir,
Okay.
one more thing is till Paul Quirk came up with this concept of circumferential resection margin, the minimum distance used to be 5 centimeters. Later,
we'll talk about it. We'll talk about it a little later. I'm talking about margins and a separate question. Okay. Yeah. So tumor markers. All right. Samir, what would you start with?
Sir, baseline CEA, sir.
Okay. What does it tell you and what does it not tell you?
Sir, it is not diagnostic.
Good.
And
no different from what we discussed in colon. So just tell me what we said last Monday. Yeah.
Sir, it is
not
more
diagnostic.
Of prognostic, more of prognostic.
Correct.
Yeah, and for surveillance and post treatment. Yes.
Okay. What if it's high when you start with? Does it tell you about the tumor load or not? When the CEA to start with is high?
No, sir.
Are you sure? Ines?
Yes, it is associated with poor prognosis, sir.
Correct. Okay. It is not meant, it's not diagnostic, but you can have it as a baseline value. But if the value is more than 5 nanograms, it correlates with higher systemic recurrence rates and hidden metastatic disease. So tumor load is an indicator for a high CEA. And of course, after you have taken it out, the CEA will fall. And if it rises again on a surveillance scale, even before you can establish the recurrence anatomically, you can have a rise in CEA, which means that you have to have your antenna up and investigate thoroughly if the CEA shows a rising trend when you are undertaking surveillance on the patient. Okay. Other tumor markers, molecular and genetic testing. Vishnu, you want to have a go at it? Vishnu, are you there?
Yes, sir. MSI, sir.
Okay. Anything else?
So HNPCC.
No, that's a different thing. That's But what are the genetic testings and the molecular testings that you do? Honestly, it is actually difficult for us to mug it up and remember it. But tell me, what is the significance of these kinds of tumor markers with respect to treatment of rectal cancer?
So by genetic testing, we can find out if we need to test for the patient's relatives as well.
Not necessarily. Okay, go on. I'm talking about the patient himself or herself. Nikita, you want to have a go?
So if any kind of immunotherapy or targeted chemotherapy will work.
Okay. Anything else?
And to know about the prognosis also, sir.
Yeah, quite right. Quite right. See, it is not of direct relevance to a surgeon. His choice of treatment, surgical treatment, is not influenced by any of these testings, but it is of extreme importance to our medical oncology colleagues. Okay, you look at the mutations, you have to choose what kind of medication that you have to take. There are some situations, for example, P53 mutations, it shows poorer prognosis and better response to chemoradiation, and also modulates response to a particular chemotherapeutic agent like an oxaliplatin. There are other mutations which help you to choose a particular kind of a monoclonal antibody. Okay, so understand that this has to be done. What is DMMR? Go on. Malavika, tell me what it is.
Sir, mismatch repair.
Mismatch repair. DMMR means deficient MMR, which is the same as a microsatellite instability, which is MSI. Okay, and this is where you use immunotherapy. All right. So the point we have to remember, you can't mug up these things. Even if you ask me to, recount this without a slide in front of me, I can't really talk. But the point that surgeons have to learn from this is, today you cannot treat a patient with rectal carcinoma without some kind of a basic workup of molecular and genetic testing, because it is of importance as far as the choice of chemotherapy or immunotherapy is concerned. And so you must involve a medical oncologist straight away, and then he will have more knowledge and experience with this, and they will choose what needs to be done. Okay. So what's the role of MRI? Ainash?
So it tells us about the like the depth of invasion, sir.
Okay.
And it will also tell us about the like where the exact location is.
Okay.
And the nodal status, sir.
Okay.
And it is also, so like if you are planning for radiotherapy, so like introducing a coil, sir, for marking, sir, like
Not secondary importance. Okay. Anyway, if you're given a choice between MRI and CT, what would you choose for rectal cancer?
sir, MRI, sir.
Why?
So because it will also comment on like basically the extent of invasion.
One
and
simple
sphincter.
statement, Ines. MRI defines soft tissues better than CT.
Yes.
Okay, CT defines bone better. Just remember that. Okay, so here you have primary staging mortality. This is really the gold standard. Rectal cancer equals MRI of the pelvis. Okay, remember that. And you can see in this picture, I've taken it from a book. You can have the tumor deposits, lymph nodes, and the involvement of perirectal tissues as far as this is concerned. Okay, so it will tell you the T category very well. It will tell you the circumferential involvement very well. And another important thing it will tell you is the vascular invasion. Okay, extramural vascular invasion. When that happens, it's a more advanced state. And so MRI gives you these important information. It will also tell you about the length of the tumor and the distance from the anal verge. And so it is one of the best modalities for us to know the staging of the disease, the stage of the disease. So endorectal ultrasound usually gives you the depth as well. Why is it not routinely recommended like MRI, or is it something that we are missing here? Samir.
Sir, for T stage, I think endorectal will be better, sir. And but then for nodal staging, it will be bad.
Is it true for all T stages?
Early disease it is.
You're right. Because the depth of penetration of the sound waves is not very good. Okay. If you have a T1 lesion, for example, where your trying to do a local excision. Okay, T1, very early stage, not beyond the submucosa. Such lesions, endorectal may do better than MRI. But for all other things, you have MRI being the best thing. So if you want to delineate a superficial lesion, ultrasound is better. So as I said, if you want local treatment for it, we'll come to the TEM and TAMIS later. But it is highly operator dependent. Like all other ultrasounds, this is also operator dependent. And so it is best if you're looking at thicker lesions or deeper lesions like beyond T2, T3, T4, an MRI is much better. And as we mentioned, the involvement of the perirectum, CRM positivity and deposits in nodes and things like that, MRI is much better. That is why MRI is considered the gold standard initial treatment for staging of rectal cancer. Srivatsa, anything else to add, please?
Yeah, I mean, what about assessment of lymph node?
Yeah, MRI is pretty good at it. And so, as I said, it separately identifies involved lymph nodes from tumor deposits and vascular invasion in the perirectal tissue. Okay, Sanat, what is the role of PET-CT?
Sir?
You go to any person today, you see rectum, the first thing they ask for is PET-CT. Is that justified?
No, sir, like this is mostly true. Mostly they do the PET-CT for anal canal cancers, usually used. But in rectal cancers, it is only used for disseminated disease where or recurrence which occurs.
Okay, so you do not recommend it as an initial workup of the patient?
Yes, sir.
Okay, can you think of some situations in the initial workup where you would probably want to get a PET-CT?
If the patient is having mets already.
I'm talking about initial workup. Okay, you're suspecting metastatic disease already. Okay, I buy that. Yeah, that's one. Anything else? Okay, there you are. It is not recommended for routine staging, but special situations, pre-op, that is initial workup, equivocal CT scan. Okay, you do an MRI of the pelvis to look at the actual tumor, local disease, and you want to assess metastatic potential. CT of the chest and abdomen you can do. But if the patient is allergic to the dye, or if he's very scared of even getting an MRI, for example, some people have a phobia about MRIs, then, or if you're looking at the bulk of the tumor for chemoradiation, you might consider that. And pre-op means that if you're given neoadjuvant treatment, all right, you're given neoadjuvant treatment and you want to look at residual disease, neoadjuvant treatment will take the form of chemoradiation. So if you want to look at residual disease, then PET-CT is a good method. And during surveillance, if you have a CEA rise and you don't have any other CT or MRI evidence of disease, then you can ask for a PET-CT. Okay, so there are very specific indications for getting a PET-CT in the pre-operative phase. Okay, I'm not asking these things because, that's why I didn't put up the answer straight away. You must know the T1, T staging of the disease and the end staging, TNM classification. So T1 is within the submucosa and the submucosa. T2 has gone into the muscularis. T3 has gone beyond the surface. If it is A, B, C, depending on how much beyond the serosa into the mesorectum, the disease has gone. Okay. T4 is gone beyond the mesorectum, and 4B is where it has involved an adjacent organ. So N1 is metastasis in less than 3 pericolic nodes. If it's more than 4, it is N2. Okay. And if it is along the main vascular trunks, it is N3. So this is the classical TNM classification that we go by. And this is a staging. Okay. It's based on invasion through the rectal wall. T1 and T2 with no nodes is stage 1. T3 and T4 with no nodes is stage 2. Okay. And stage 3 is regional nodes, any of them, 1 and 2. And M, of course, if you have metastasis, it is stage 4. Again, you don't have to mug this up. This kind of a table is available to you everywhere, very freely on the net. So when you see a lesion, when you do a workup, get an MRI, get the CTs that you need, you can easily talk about the stage. All right. Cancer rectum is the very classical example of multimodal treatment because it's not just surgery. So we need to know the role of each of these people in the treatment of cancer rectum. Okay, so Vishnu, have a go. What is the role of a surgeon, role of a pathologist, the radiologist, and the oncologist?
So the role of the surgeon would be to first to diagnose that the patient has rectal carcinoma. That is, and then
with the help of the pathologist,
to decide, yes, sir, and then to decide whether the patient is suitable for surgery or whether they are inoperable.
Okay.
And then, if operable, to do the actual surgeries.
Correct. Which kind of surgery he has to decide. Good. What does the pathologist tell you?
So the pathologist can do the grossing as well as do a histopathological examination of the tissue,
Right.
as well as ask for and get genetic and immune markers tested.
Correct. Correct. Radiologist.
So the radiologist, there's the radio diagnostic side from which they can assess the extent of the tumor.
Staging of the disease, in short.
Yes, staging. And
right.
Then the
oncologist?
oncologist will give the radiotherapy.
Only radiotherapy? Medical oncologist?
Yes, sir. The radiation oncologist will give the radiotherapy. The medical oncologist, in partnership with the radiation oncologist,
right.
can
They
plan on
decide
the
about whether they
and
need to give neoadjuvant chemotherapy before surgery,
yes,
or whether they have to give adjuvant chemotherapy after surgery. Okay, radiologist gives you staging, and the surgeon will diagnose it, as you said. Think about possibility of sphincter preservation in low rectal carcinomas, post-op surveillance. Okay, and the pathologist gives you grading of the disease, not just staging, because grading is important for the choice of surgery at times. We'll learn about it as we go along. He'll look at biomarkers and at surveillance. So truly, rectal carcinoma exemplifies the need for multimodal treatment, and the multidisciplinary meetings that are described in oncology are very important in rectal cancer. Okay, treatment overview, I'll give it to you straight away because, okay, this is a simplified version. More than enough for our postgraduates. MCH oncology may go into a little deeper analysis of this. Okay, proximal or distal tumor is what is important. Lower third tumor has a different approach to the upper 2/3, middle and upper third rectal cancer. If you have a early lesion, T1 lesion, then you can consider local excision. If you have, for a distal one, you think of local excision even more. If there is any suspicion of T2, you can consider restaging with neoadjuvant treatment. For high risk locally advanced tumor, you always give neoadjuvant treatment followed by restaging and surgery. So remember, only in T1 and very select cases of T2 will you think of surgery first. Unlike cancer colon, where most of the time you do surgery first, here, unless the tumor is very early, T1 or T2, you do not consider surgery, you go for neoadjuvant treatment. Okay, so Pravina, indications for neoadjuvant treatment.
So,
Go on.
indications.
Indications.
Sir, no, metastatic.
I've already given you one. I've given you one answer straight away.
Sir, local invasion.
Yes.
And
T3, T4, straight away.
yes,
Neoadjuvant. Okay.
yes, sir, T3.
Okay. What
And
else? I gave you the second answer already. Downstaging in lower rectal cancer.
yes, sir.
Yeah, because you want your very best to avoid an APER and try and preserve the sphincters. Okay, Samir,
Yes, sir.
you want to add anything?
Sir, first is stage 2 to 3.
Yeah,
Then
don't repeat what I said. Yeah, we talked about downstaging and T3, 4. Yeah, stage 2, 3. Yeah, okay.
yes, sir. Sir, any MRI defined high factors, sir, like
Okay.
EMBI positive or the...
Yeah, quite right.
Yes.
Okay. T1 and T2 lesions with positive notes, not necessarily T3. We mentioned low situated lesions, invasion of mesorectal fascia. Okay. And if you have extramural invasion, including lymph node involvement, and as you said, vascular involvement and tumor deposits in the mesorectum, the ones that we showed when we showed the MRI picture, you would consider neoadjuvant treatment. So most of the patients that you see with rectal cancer nowadays go for neoadjuvant treatment. Okay, what are the options available? I'm not an oncologist, medical oncologist, but as a surgeon, you must know briefly the options for neoadjuvant treatment. What are the kinds of neoadjuvant treatment they offer? And that is important because you must know when you can do your surgery after the neoadjuvant treatment. So in that context, what can you tell us? Sanath. Are you there? Okay, Nikita?
Yeah, sir.
Oh, you're there. Okay, go on. Yeah.
Yes. Neoadjuvant treatment modalities can be both chemo as well as radiotherapy, sir.
Correct.
And
anything else other than these two?
Then
we talked to you about the importance of tumor markers.
Yes.
And what you do in a high MSI situation. And the positivity of P53 was another thing that we mentioned.
Immunotherapy.
Yes,
can also.
immunotherapy. Okay. So radiation, chemotherapy, immunotherapy. In radiation, any variations that you have? Okay,
there is
that's too much to ask. I'll give you the information. But when would you do surgery after neoadjuvant treatment?
After 3 to 6 months, sir. Like 3 months, we will recheck.
Can you be a little more? Yeah. Okay. 6 to 8 weeks is more like it. Yeah. So the
Yes.
logic, why 6 to 8 weeks? Why not earlier? Why not later? Nikita, you want to have a go?
Sir, it affects the bone marrow and all suppression and everything. So
bone marrow is not what we were worried about. Ravina?
It might cause inflammation.
Yes, too early will be inflammation. Too late will be fibrosis and recurrence of disease. Okay, it will debulk it, but if you leave it for 6 months, the disease may come back. It can also cause fibrosis, desmoplastic reaction to radiotherapy or even chemotherapy. And so 6 to 8 weeks is the kind of margin that you have. But there is one modification to that, which is of more recent development. It is a short course standard radiotherapy. Okay, they give a very short course, unlike the prolonged 3 to 6 sessions of the standard chemotherapy, in which case they say you can operate within a week of the end of that radiotherapy session. Okay, what is your go on?
So that is actually the 2004 paper from the Dutch trial Capitaine et al., which showed that the local recurrences can be reduced from around 20 to 25% to about 1.2 to 2.4%.
Yeah.
So that was a short course radiotherapy of 5 days of 25 grays, and then 2 to 5 days or 7 days after the completion of radiotherapy, you operate on them.
That was
that was the short Dutch trial, but the problem was they showed that the upper rectal cancers you don't need to give radiotherapy. So I think that sort of put the cat among the pigeons, but now it has come back again.
That is the point. Yeah. So it has come back more recently in the context of total NACT, neoadjuvant treatment. What is this business of total neoadjuvant therapy? That is actually only about 5 or 8 years old. Total neoadjuvant therapy. What is your understanding of that? That's now become a standard of care.
So all chemo and radiotherapy is completed before surgery.
Correct. All of it that they were giving, after combination of neoadjuvant plus adjuvant treatment that they were giving is given all in one go in the preoperative phase. That is total neoadjuvant treatment, and that has been shown to be equivalent to prolonged adjuvant therapy, that is post-operative therapy. There is good response to that, and I'll give you some more information about it. And so that has now become the standard of care. When that happens, you usually operate between 6 and 8 weeks after the completion of the neoadjuvant treatment. That is of importance to surgeons, timing of surgery. Okay, Srivatsa, anything to add, please?
Yeah, it could even be a primary modality of treatment.
Yes.
The tumor might disappear.
Correct.
And
we'll come. Yeah, you're absolutely right. I'm going to give that information in a minute. Okay. Yeah, that's true. Very true. Yeah, go on.
So as you said, the TNT could be considered as primary modality of treatment. The other thing is the patient choice, and these things come into play, and especially elderly people who cannot tolerate major surgery.
Correct.
And people who do not wish to have stoma.
Yeah.
So such people, TNT can become a boon. And the advantage of this is that even if the recurrence happens after you have done this,
I'll come to that. I'll come to that in a minute. Yeah, because all this is in a sequential manner. So you understand that we talked about radiation and chemotherapy, and as I mentioned, in the high MSI or deficient MMR situations, immunotherapy is what you have to give. Okay, that is what I mentioned. And Dr. Srivatsa mentioned about response. Okay, it's called a CPR or a CCR, complete clinical or complete pathological response with the neoadjuvant treatment. Okay, which means that the disease actually disappears. So any idea what percentage of disease disappears when you give total NACT? Okay, so that is it. 28% can disappear. All right. So then you have an issue. What would be that issue? This is the issue. What do you do if the tumor that you have seen, sent as a surgeon, you have diagnosed it, you have staged it, and you send it to a medical oncologist colleague? He gives NACT, and then you see it again. Nothing is seen there. What should you do? Nikita.
We can wait or watch, or we can plan a surgery, sir.
Okay. What surgery would you plan?
So considering the primary location of the tumor.
Right. Whatever is correct. That whatever the tumor decides, the location decides, you do. Agreed, along with some other factors which we'll again discuss. All right. But is it safe? What if the cancer is brewing underneath somewhere? Is it safe?
Not sure.
So if you want to be sure that you're not missing, there is a submucous survival of cancer, doesn't see anything, you don't see anything on the mucosal aspect, even if you're putting the patient under surveillance and suddenly the patient comes to you with metastasis. You'll be kicking yourself for not operating. So what does the data show about this situation? Anas?
I'm not sure,
Not
sir.
sure. Okay, fair enough. That really is an advanced question, but this is your answer. I put one representative study here. There are many studies now. You understand that in this Manchester study of 2015, they looked at 129 complete responders with no surgery and compared them with 228 patients who did undergo the standard resection, whatever it was, according to the location. Okay, at 33 months, nearly 3 years, okay, 34%, that is a third of them, had a tumor. They were under surveillance, they picked it up, and 80% of those had a resection. Okay, and disease-free survival at 3 years was 88% in this group, 78% in the resection group. That is the same, not clinical, not significant, statistically significant. And look at this interesting thing. All these, as I told you, are relevant for low rectal carcinoma because you want to avoid an AP-ER. So with this follow-up, at 3 years, 74% of them had no colostomy. Whereas in resection, there were only 47%. Because it was low tumor, they all had to have an AP-ER. So the conclusion is very simple. Wait and watch, and you can watch them every 3 months, keep getting CEAs, keep doing sigmoidoscopies. And what are the significant features do you think in the sigmoidoscopy that you must look for? Can you guess, Vishnu? What do you think will show a tumor there? One of them is a lump. Right? A tumor is a lump.
One would be bleeding.
Not necessarily bleeding. Lump or a crater or an ulcer should not be there. Okay?
Right.
What can be there? What is allowed?
So polyps are allowed.
Polyps are not allowed.
Right.
It should be flat. I already mentioned it. Okay?
Right.
You can have a white scar and you can have telangiectasia. That's a reaction to chemoradiation. You can have prominent blood vessels. There cannot be an ulcer. There cannot be a lump. And you can take biopsies at random in that area which looks scarred. And if you have any positivity, that's one indication. What else can you do? This is an indication for a PET CT.
PET CT.
Okay?
Yes.
When you're under surveillance, okay, if the CEA goes up and you find that on sigmoidoscopy surveillance, it is still flat, it's only telangiectasia, no ulcer, no tumor, you're still worried, get a PET CT. If you see a metabolically active lesion in that area, it means the disease has come back. Okay, so this is the current standard of care. If you have complete CCR, complete clinical response, watch them and you will not be doing any harm. Okay, I had a classical case of a 55-year-old lady just last month. We were watching her. It had complete response, and at 9 months after that response, she was on a 3-monthly sigmoidoscopy. When I did a sigmoidoscopy 9 months after her initial NACT completion, she had little lumps, little bumps, like papules or very small polyps in the area. I biopsied it, it came back as positive. So we did an AP-ER on her. Okay. So that is a classic situation of where you can wait and watch. Now we come to our subject. I'm sorry I've spent so much time on this. It's already 9:53. Maybe we should take another class on this because rushing through things won't be very good. What do you say, guys? And going on for hours together also is not very good. Nikita? I think
Yes.
we'll talk about surgery in another class, maybe
Yes, sir.
Yes, sir.
next week or
Yes.
something. Okay, because there is quite a lot to discuss in surgery also. I wanted to keep it short, but I felt that this kind of discussion was important. Okay, we will stop here today. But before we stop, questions or doubts from the students and registrars? We are all students, but yeah, but we are
So,
3 teachers here. Yeah, go on.
so this wait and watch, like the strategy, it is applied to any staging which is showing complete response.
Correct.
Like even if there was in lymphovascular invasion or nodal
Yes,
positivity, you can.
yes. The answer is yes. Once you give the neoadjuvant treatment, you do your MRIs, you do your PET CT, you do your local biopsies and all that. Then you decide that there is no tumor left. That is complete pathological and complete clinical response. Then you wait. But if you have very advanced disease, that kind of complete resolution is unlikely. It's more likely to be stage 2 disease, for example. An occasional lymph node, maybe N1 stage, which T2 or T3, that kind of tumor responds very well. And of course, its characteristics are important. The molecular markers must be conducive.
I do have a question.
Yeah.
So every 3 months we have to repeat CEAs.
Yeah.
CEA. What about colonoscopy, sir? How frequently
Sigmoidoscopy.
should
You don't need colonoscopy.
Right,
Yeah.
sir.
Every 3
Yes,
months.
sir.
Every 3 months. Yeah, you should do a sigmoidoscopy.
Right, sir. And PET CT would be once a year, I suppose, sir.
Not
How
unless the
frequently?
not unless the CEA is rising or you have some other indication that there may be disease.
Okay, sir. Right. Thank you.
Yeah. So closing remarks, Srivatsa, please. You have anything to add or say about what we have discussed so far? Unmute, please. You're muted. Yeah.
Excellent discussion, I said.
Yeah. Thank you. Ravi, you're.
Yeah, I see just a background,
Yeah.
initially when the surgeons used to do resections, the problem was many of them would go for AP resection because the margins were considered initially 5 centimeters. Later it became 2 centimeter. When Paul Quirk from Leeds.
We'll talk about that later. Yeah.
Okay. Other thing is the Gina Brown, who is the radiologist, MR radiologist from Royal Marsden. She showed that she could actually stage it as well radiologically as well as a pathologist would do, because she compared the MRI staging and then after the specimen resected, they compared the staging and showed. So hence, that is why MRI has become the cornerstone of investigation as far as rectal cancer is concerned, and hence you can actually use it preoperatively and then comparatively postoperatively to see whether there is pathological complete response. The other thing is, once there is PCR, the overall survival, disease-free survival is very, very good. Hence, the other thing is, if you can wait and if there is recurrence and you operate on them, their survival is equivalent to people who actually underwent surgery before.
Correct.
So that is the advantage of actually wait policy, what Ainas was asking. So that is the advantage. You will not endanger the patient's survival anyway if you wait and watch. Of course, as sir said, in certain special circumstances, if it is a very advanced disease initially, then you would, and especially younger patients, you would certainly offer surgery at the completion of the complete neoadjuvant treatment.
All right. Okay. Thank you very much. I think that was quite a useful kind of session. Nikita, you talk to me and then schedule the surgical part at some other stage. I don't want to disturb anybody else's teaching schedule. So at some stage, we will discuss about the actual, we are surgeons, we need to know about surgery, but we will not rush through it and we will talk about it in the next session.
Sir,
okay.
Sir, please ask your registrars to attend our other classes also.
Yes, their
inputs will be very useful.
Yeah, it's true. Because but they have passed their MS, you see, and they feel that they need not come. But I think I will blackmail them. I twist their arms. I will push them to attend these classes.
So I have a small request.
Yeah, sorry, yeah.
Reading an MRI
Yeah.
is difficult for a surgeon. I think we need to have a radiologist telling us a little bit.
Yeah.
Well,
very true. Very true. We'll do that. We will get our radiologist to talk to us. I completely second that. I can read a CT with reasonable confidence, but not an MRI. Yeah.
Sir, but we should also get Swaroop to come to one of the classes so that he can give us the, I think the next class, initial 10 minutes.
No, I have mentioned this to Nikita already.
Yeah.
He must have a full class for himself.
Okay.
About the medical oncologist view of cancer rectum. It's a huge topic, and I hope he makes it simple for surgeons. But we should listen to him for whatever we can retain. We can, but we should listen to him in a complete class.
For all you know, immunotherapy has made a remarkable advance in rectal cancer.
Correct.
Yes.
Correct.
Complete clinical response, particularly.
Correct.
So the other thing is for the MR rectum, there is a special rectal call which is used, which will give all the information. That is just for. Thank you.
Correct. Thank you and good night. I'll close the meeting.
So I have a small request to make of you. Hello.
Sorry?
I have a small request.
Yeah.
Sir. The slides you have made for this, could you share them with us if you don't mind? Sir?
Sure, we'll do that. And the recording will come on the YouTube as well. I'll send you the link also. So if you want to listen to it again, you can do that. Yeah.
Sure, sir. That'd be great. Thank you so much.
All right. Okay. Bye-bye. Good night.
Good night, sir.